On behalf of the Northwest Mental Health Technology Transfer Center, I'd like to welcome everyone to today's webinar. I'm Sarah Kapelovich, a licensed clinical psychologist, member of the Northwest Mental Health Technology Transfer Center, and the director of the Northwest CBT for Psychosis Provider Network and CBT Echo Teleconsultation Clinics. In response to the pressing need to maintain care continuity through the use of telehealth, I was fortunate to recruit Dr. Tania Lecomte, professor of psychology at the University of Montreal, to join the Group CBT Echo Clinic that my team and I at the University of Washington host bi-weekly for our CBT for Psychosis trainees. The CBT Echo Clinics are funded by the Washington State Healthcare Authority and provide ongoing support to new and veteran CBTP learners and practitioners. In an effort to share Dr. Lecomte's expertise on this topic with the broader behavioral health workforce, I'm pleased to offer this webinar in collaboration with the Northwest MHTTC. For those who are not familiar, the MHTTC is a nationwide network of training and technical assistance centers funded by the Substance Abuse and Mental Health Services Administration. The MHTTC network consists of a national coordinating office, 10 regional centers, a tribal affairs center, and a Hispanic and Latino center. Together, our collaborative network supports resource development and dissemination, training and technical assistance, and workforce development to the mental health field throughout the United States. Broadly, our goals at the Northwest MHTTC are to heighten awareness, knowledge, and skills of the workforce addressing the needs of individuals with mental illness, to accelerate adoption and implementation of mental health-related evidence-based practices across our region, which encompasses Alaska, Idaho, Oregon, and Washington, and to foster alliances among culturally diverse mental health providers, policymakers, family members, and clients. It's our intention to always be mindful of using language that promotes recovery and is culturally appropriate. We encourage all clinicians to use and champion person-first language, which emphasizes the individual rather than a condition or a disability. Person-first language is a way to demonstrate respect for a person's dignity and worth. It is consistent with recovery-oriented practices and promotes treatment environments that foster respect, human dignity, and hope. It's my pleasure now to introduce Dr. Tania Lecomte. Dr. Lecomte is a full professor in the Department of Psychology at the University of Montreal, a senior researcher with the Research Center in Mental Health at the University of Montreal, and a clinical psychologist. Dr. Lecomte has helped to develop and validate assessment tools, as well as several group interventions for individuals with serious mental illness. These groups include a self-esteem enhancement group, CBT for Psychosis, CBT for parents of individuals with psychosis, CBT for supported employment, romantic relationships in early psychosis, as well as mindfulness, acceptance, and compassion groups. Some of these protocols are now being used across the globe. Dr. Lecomte has been the recipient of both Canadian federal and provincial grants over the years. She has published more than 120 articles and 4 books in CBT for psychosis or psychiatric rehabilitation. Dr. Comte is the first to pilot a study looking at group teletherapy for mental health problems, and she will be informing us about this work today. Without further ado, I welcome Dr. Lecomte to begin her presentation.
So actually, what I'm going to be talking about today is not, I don't have that much content, but I really kind of want to share with you our experience with doing Group CBTp via teletherapy. We've been doing it for about 2 years now in the context of a pilot study. So I kind of wanted to go through the different kind of the reasons why we developed it before the pandemic. It had nothing, we did not know, okay, we're not part of the problem. we weren't in the conspiracy to get this to happen. So so we just, we had this in mind, and a few years ago we started with this pilot study with very little funding. So I don't have a lot of data, but I kind of wanted to kind of give you an idea of what the the kinds of problems you might encounter, solutions that we have come up with, things that might need to be modified in order for things to run smoothly. The reason why we really decided to go in this direction initially is because, well, as you know, many individuals with psychotic disorders, they live in remote areas. And I strongly believe in Group CBTp, and I really believe that for a lot of people, especially people who are isolated and youth, to have access to a group can really make a big difference. It can help them feel connected with others. It can help with socialization. It can also help feel like less alienated, that you're not the only one going through this. Learn interpersonal learning from others, their strategies. And I really thought it was sad that when I was going around doing workshops in some regions, they were saying, well, you know what, even if we wanted to offer it, people, it would take them 2 hours to come to the group because they live in such a wide territory that it was inaccessible. And so that was one of the reasons initially we said, you know what, it would be really important to find a way to get people to have access to group therapy, even though they're living far away. So we figured it would actually give them the support and the group experience, but in their own home. We also initially, that was our first goal. Okay, people who live in remote areas. But then we realized that a lot of people, and as I mentioned, we were thinking this before thinking that we would all be on lockdown. So who else would benefit from this? And we realized that some people that we approach for groups, like they can't make it. Either because they have social anxiety, either because they have difficulties with public transportation, or they have too many like negative symptoms and they have low motivation. So once they're in the group, they love it, but it's really hard for them to get there. And especially people with social anxiety, the group might be a little bit too overwhelming in person. But surprisingly, online is not as bad. It's not as difficult. So we figured, well, if we're able to offer a group that's online, that teletherapy, that people can access from home, well, it might be useful not only for people who live in remote areas, but it might also be useful for people who live in cities but would not otherwise have access to a group intervention. So what is it that we know? So we kind of went through a bit of a literature review saying, well, what do the studies show? I mean, is it worth it to go in this direction, or what if it's not as good? And so all the studies that we went through, and well, most of, I have to admit, most of the studies that use teletherapy use CBT. Okay, that's like essentially most of them. Most of them also, actually almost all of them are all individual therapy. And so, and when you look at these studies, look, the results are actually quite good, and there's no significant difference between in-person and online. And there's a meta-analysis of SPEC from 2007 for anxiety and depression. They found similar results online and in person. PTSD, similarly. So there are several studies that went on and even measured things like the Alliance and saying, well, is the Alliance as good in person as online via teletherapy? And they found that it was similar. And I'll come back to the idea of the Alliance later on, but that's a big worry often that therapists have. It's like, well, if there's a screen, will I be able to connect with my clients? Will they feel this connection? Will we be able to create that group cohesion, that feeling that we're together if we're all in front of a screen in our own homes? And that's often a worry that we have as clinicians, but you'll see from our experience what happens with that. There were no studies for online teletherapy for psychosis when we did our review. And I don't even think that, well, unless some came out recently, but I didn't see any at the time, and even a few months ago. But we know that CBT for psychosis, and all of you know that it's very effective and it's accessible, and Group CBT for psychosis as well. And we do know that people with mental health problems often tend to be quite isolated. So we figured this would be something that could actually go out and reach more people. Of course, we did not know that we would have a pandemic and that even more people would need it, because now everyone's isolated and in seclusion. So that was something we didn't think of. So it's even more useful now. The other thing is that youth in particular, and when I'm talking about youth, I kind of say it in the large term, like, 30 years old and younger. The younger generation, let's say, or young adults and teenagers, they're actually very open to new technologies. Using telehealth with people who are older, especially if they're not very technology sound, might be a bit more of a hurdle. Like, you might have to assist them and help them go through the steps. But the young people, especially the early psychosis, it's really easy for them. It's something that they're open to, and that we've actually had quite a few people who are more keen to doing things online than doing them in person. Now, as I mentioned, we didn't know, we had never seen it offered via the internet for CBT for psychosis. So our pilot study, when we decided to offer it, we looked around and we hadn't seen any other groups that had published about group interventions for a mental health problem. And we went around, and I remember really looking, this is like 2 years ago, and the only groups that I found were online. They were groups for people, they were support groups for people who had a physical health problem, like a group for people who had cancer. So a support group for people who had cancer or some other physical illness. And I didn't see any group interventions that were done in teletherapy for a mental health problem. So when we actually proposed our pilot study, we couldn't actually say, oh, we know that group interventions online work, because there weren't any examples that were published at the time. So our pilot study was kind of the first one to provide group teletherapy via the internet for a specific mental health problem. So what we wanted to do, well, our objectives were, I guess, twofold. We really wanted to see, will we get similar results? Like, is the group teletherapy in person, will it be similar in terms of the results of what we get online with teletherapy? It's just really, I guess, the biggest question is that you don't want to offer something because it's practical, it's useful, but then it doesn't help that much. You really want to make sure, if you're offering it, that it's going to give the results that you're hoping it should give, that you find in the other studies, that all the other effectiveness and efficacy studies have found. So that was kind of really our first concern, is that, well, is it worth going in that direction? Are we going to get similar results? I'll be honest with you, the therapists were quite worried that the alliance and the group cohesion would not be as strong. And that's something that comes out often when you're proposing to do teletherapy. And I don't know if some of you have seen this with the pandemic, but I also do private practice, and I'm on like chat groups of people who are psychologists in private practice. And when people are transferring over to teletherapy with the pandemic, it's something that comes out a lot. People are worried, what if it breaks the alliance? What if the alliance won't be as strong? Can I start a new client via teletherapy if I don't already have a strong relationship with them? And that's something that we also encountered, that the clinicians who were going to do the groups, some were worried that the alliance and the group cohesion would be harder to build because of the screen, because of the distance. And so it's something that I wanted to mention to you, because something that comes out often. The other thing we wanted to see is it actually feasible? When we're talking about offering teletherapy in remote regions, well, it means that some of these regions might not have super stable internet. Some of these remote areas, it might be difficult to make sure that people have access to the right technology or to the right internet speed. We wanted to see if it also worked in cities as well as in remote areas. And so some of the clinicians, some of the clinics actually were kind of concerned. Like, everyone was open to the idea. They, like, this is novel, this is high tech. But we did get quite a few people saying, well, I'm not sure I want to refer clients to you, because what if there's a higher dropout rate? What if, you know, people don't connect and they just drop out of the groups? And so that was another concern, like, would we get higher dropout rates? Will people miss more sessions because they don't feel that they belong as much? So I'm just telling you what the concerns were, and you'll see what we got. So it's a pilot study. We didn't get a lot of funding. This is like a bit of money from the foundation of the hospital. So we've conducted 3 groups. The last one is still underway, so I don't have the data from all the 3 groups. I have data from the first 2. So the first group that we did was last year, and it was from 2 small towns that are 5 and 6 hour drive from here. So the towns were like 1 hour apart. So like about half the participants was from like one town, and the other half of the participants were from the other town. And yeah, the 2 towns were about 1 hour apart. And so from Montreal, for me, to get to them would take 5 hours to get to the first town and 6 hours to get to the second town total. So that was the first one we did. So they were really our, I guess, our guinea pigs in many ways. And I'll explain everything we had to go through with them. We had technology problems. So all the things that went wrong with them. But surprisingly, even though we went through a lot of difficulties in the first few weeks, they stayed on. And when we asked, how come you stayed on? Participants said, well, you worked so hard of making it happen. So you were so motivated. We didn't want to let you guys go. And so we saw how much you cared about us getting the intervention. So it really made us feel wanted and feel that this was important. So they kept on, even though things were not always easy. And I'll come back to that. So that was the first one we did. And then we did one in the fall in a large suburb outside of Montreal. So it's about maybe 45, 50 minutes from here. And that was they were all from the same clinic, but it was in large suburbs. So if they would have had to come to the clinic, it would have all taken them more or less 45 minutes to 1 hour to get to the clinic, because they all live quite far apart, and the suburbs don't have really good public transportation. So for them, it was also something that they thought was a good addition to their services, to being able to offer it online. Whereas the 2 small towns, the reason why we had from 2 towns is that each one, their first episode clinic was like too small, like not enough people would have agreed to take part in the group. They wouldn't have been able to do a group within the town, even though the towns were small. Like, it's not so much that it would have been far for them to come to the group, it's more that they wouldn't have enough people. So by offering it in more than one setting, they were able to have enough people for a group. And the one that we're doing right now that is going to finish, I think, in a month or so, is with teenagers. And because we wanted to, our study was between the ages of 14 to 25, no, 14 to 30. And so we wanted to see if we were able to do it with the under 18 and less. And so we have one group that were recruited from I guess it's a pediatric hospital, a psychiatric hospital. And so these are all teenagers. So cognitively, they're a bit more challenged, because when you get your first episode, you know, at 15 or 16, sometimes like you have a history of being followed. So I guess the challenge has not been so much of the teletherapy, but the challenge is more of it, I guess, making sure everyone is able to understand the concepts, because that can be difficult for people with very important cognitive deficits. So this group was, I guess, more cognitively impaired, but it's still going on. It's still going great. And so I don't have results for that one, but that's the group that we have ongoing at the moment. We have 2 other groups that are ongoing, but they're not CBTP. Because of the COVID and because, well, I've been doing groups since I was younger than Sarah. No, since I've been in my 20s. with Claude Leclerc, who's one of the co-authors of the book, who's retired now. He's a psychiatric nurse, but he's retired. I just called him up and said, you know what, you feel like doing some volunteering? Why don't we just run a group for people who are isolated because of the pandemic, who have psychotic symptoms, who have a psychiatric illness, a severe mental illness, and who would like to, you know, talk to other people, share what they're going through, and maybe share strategies, coping strategies of how to cope with what they're going through at the moment. And so we've been offering this every Wednesday for the past 2 weeks. Now it's our 3rd week this week. And anyone, it's free, anyone who speaks French, click on the Zoom link and they come online. And it's been going great. People love it. We've been getting a lot of positive feedback and we even had someone from New York who came on last week, but who spoke French. Like I think there's a need for groups, online groups for people who are isolated at the moment. So I think it's a good timing for you guys to start this. We also had a group that had started in person. That was a group, it's our Power of Two group. It's a study we're doing with people, with young men with psychotic symptoms who want to develop romantic relationships. So it's a CBT base, but it's on romantic relationships. And that group had started in person, but we had to stop it. So we converted it to a teletherapy group. And that's also going on and going well at the moment. So we have a bit of experience running groups via teletherapy at the moment. So the problems we've encountered. Okay, we've encountered quite a few issues. The first one is that some participants do not have the right tools. For a support group, I don't really mind if people log in with their phone, because the idea is really for them just to get support. But for Group CBT, one of the reasons why it works is that you're able to create this group cohesion. Like, you really get this feeling that people appreciate each other, they want to help each other out, that they're there not for themselves but for the other participants in the group. And you can't do that if you see people like this big on their screen. So it's important that they have minimally a tablet or a computer. And so with only phones, it doesn't have the same impact. So we actually I went online and I bought secondhand iPads and just lent them the iPads for the time of the study and for the time that we were doing the groups. And once the groups were done, we just, went back and picked up the iPads. So that's one of the things. I think it's really important to make sure that they have the right technology. They need to have an internet connection that is good enough. Currently, what's going on is that if everybody's online at the same time and somebody uses the microwave, the connection can crash, right? So these are little things that, because there might be more people at home at the same time, more people on the internet, well, you might say, well, could you ask for the other people at home to not be watching Netflix or not be online at the same time if your internet connection is not super powerful? Because even with a good powerful connection, if you have too many people in the same home that's on the same internet at the same time, it's possible that they get disconnected, and the microwaves do that as well. They can get you disconnected. So that's a thing to watch out for. One problem that we did have is that a lot of clinicians wanted to offer the group, like we tend to do our groups late in the day, like at the end of the day or early evening, because, well, some of our participants, they were going to school or they were working. Right now, it's not an issue so much because everybody's in confinement. So like right now, my support group, I'm doing it at 4 in the afternoon. So it's really not an issue as much. But there are some online classes, so some are still doing their schooling, and some people are working, even though it's not that many. So sometimes, like, some people might say, oh, well, I'm going to do it at the end of the day after my shift. And then they wanted to do it at the hospital or at the clinic. Well, I don't know how it is at your settings, but we had some settings that did not have great, because of the firewalls, or the internet did not work too well with them. So when they were trying to do video conferencing, it would crash, or they wouldn't get, their camera wasn't working properly, or the computers that they had at work did not have cameras. And so if they wanted to use an iPad, like the Wi-Fi wasn't stable. So these are all like little technical things that made it really difficult for the clinicians to offer the group from their work setting. And either because of the firewall or because of the technology, or they had to use a cable connection, but their computer did not have sound. So we ended up asking if they could, negotiate with their employer to, maybe start their day a bit later, and then work from home afterwards. So do the group from home. So that's something that we had to do for quite a few people because of these firewall or internet or computer issues in the clinics or in the hospitals. And the same with people who got hospitalized. It would happen, say, during a group that someone wasn't feeling well and went to the hospital. Well, sometimes during the time of the hospital was really hard, even though they had their iPad. The Wi-Fi wasn't good, so it's really hard for them to continue coming to the group while they were at the hospital because of these internet problems. So these are things to watch out for. We tried several platforms who had problems. I heard the problem with Zoom earlier, and I think that I wouldn't worry so much, because Zoom, what happened is, like last week, or I think it's 8 days ago, pirates intentionally went into Zoom to show that their security was not foolproof. But these were computer pirates, and they were really good. And they went through Zoom, and they actually were able to mess up some meetings, and these were not therapies. These were professional meetings, and I think they did it intentionally, because Zoom has been making a lot of money recently with everybody using it, and this created, well, on one side, kind of a phobia towards Zoom, but on the other side, it forced Zoom to even increase their security. But when you compare Zoom to all the other platforms, their security was already much better than all the other platforms. Now they have to make it even better. So I'm not really worried at the moment, because Zoom has like really increased the security, and it was already much better than the other ones. If you're gonna use another platform that's not Zoom, really verify the security, because not all of them are as encoded and secure as Zoom is currently. So we tried several platforms, and initially it all looked good, and then we'd have, we realized that they say, yeah, you can be up to 50 people on it at one point, but then in the small print, no more than 4 iPads at a time. Apparently iPads is a different system than a computer, and because most of our participants did not have computers, to have people with iPads or their phones with the image at the same time, not all platforms accepted this. And so to find a platform that you could have 7 people with iPads, if that's what we had, at the same time, or 8 or 10, that took us a bit of time, and that's how we ended up with Zoom. It's a paid version that I use. It comes up to $25 US a month, so it's not cheap. But you might be able to, now currently our institutions are paying for it. I mean, I still have my own private license for my group studies, but because it works, I have it, and so I'm keeping it for the studies. But I know that that more and more it's possible that your institution agrees to pay for it for the time of the groups, or it's not that expensive. It's expensive if you pay it yourself, but it's not that expensive if your clinic decides to pay for it. It's $25 a month, and it gives you access to as many people as you want, as long as you want, and there's no time limit. So that's one thing that we had. So we had several, when I mentioned several platforms. Sometimes like the sound would stop or echoing, or the image would drop, or someone could not go in. Like he'd come, he'd listen, but we wouldn't be able to see him. And so, and with Zoom, we haven't had any problems, and we've been using it. It's our second year now. And so, so it works really well. Another problem that we had, and is that we had one participant that had an internet addiction, actually had a porn addiction, and that giving him an iPad for the study, well, it just kind of triggered the addiction back. So even though he really enjoyed coming to the group with his case manager, they kind of decided that he had to withdraw from the group because having the iPad was too much of a temptation to go back into his porn addiction. So that's something I hadn't thought of before, but that some people might actually have internet addiction, and you know, not so much on your small phone, but if you get a bigger, you know, device, it might actually be a problem. So certain rules that you kind of have to think about when you're doing teletherapy. I guess the first thing we really have to mention is what to do if you have technical problems. It's something that you have to say from the start, because even though people are able to get online and all seems well, it can happen, okay? Somebody uses the microwave, you're shut off. What happens? Like, how do you tell the person they can get back on? What we typically recommend is, like, with Zoom anyway, you have also a phone line that they can call. A lot of the platforms have that. So if they're not able to come back via, you know, video and sound, to call, and then we can maybe assist them on the phone to help them get back on. Sometimes it's just to unconnect, leave the room and come back in, and then they're okay. We make sure we have everyone's cell phone number, and we text them, like, is everything okay? I saw you came in and you left. And so one of the co-therapists can text and see if there's a problem to kind of assist the person. Sometimes it's usually in the first sessions, if there's going to be technical problems, that it happens in the first 1 or 2 sessions. But once people are able to get on and connect, then usually they're okay for the rest. Then it's really up to you. To make sure people don't forget, we tend to send a link every week, you know, so it's not, that's a way of, like, you know, reminding them, okay, don't forget, like, in our case, we do the group twice a week. So twice a week, like the day before, we resend them the link, like, don't forget tomorrow the group, and we send them the link, so they only have to click on it and go right into Zoom. So that can be also a way of making sure it's not too complicated for them, that they don't have to, like, remember the code or remember the room. We also ask them, and that's really important, that they have to guarantee us that they can be in a private room. It's really hard right now with the pandemic. Sometimes there's a lot of people in a small apartment. I've had people go in the bathroom for their group, but we ask them to be in a private space, because there's still confidentiality issues. There's people there that we might not want others to know that they're in that group. So we ask them, please, you know, make sure no one can come in the room during the time of the group. Ideally, we ask them to do the sessions with earphones, so that whatever's being said in the group, not everyone in the room can hear it. We had once a problem with this girl was living with her boyfriend, and he kept on strolling in the room and making jokes about the participants on the screen, thinking he was like a hot shot, you know, haha, look at these idiots. And it was really disrespectful, and it also made the group really uncomfortable, because they felt not judged, but they felt their privacy and their confidentiality was broken. And so we had to work with this girl as, like, well, either you find a private space, or you're going to have to leave the group. And so that's something that's really, really important, that to make sure, even though it's hard, I say, you know, worst case scenario, go to the bathroom, you know, and lock yourself in for an hour. But it's important that people feel safe. And that's one of the important, in any group, you want them to feel safe. And that can only happen when there's no disruptions or people coming in all the time. All the other rules that we usually use in the groups, they apply, you know, that, and we make them vote at the beginning the same way, like everyone's has to respect each other. We don't judge. Everyone gets a chance to talk. We might ask, you know, to just like lift their hand to make, so we can see who wants to talk. We ask them to be on time, to, you know, respect confidentiality issues and so on. So those are all the same. To not accept the messages during the group, so to shut off their phones, and to not be on, you know, on Instagram at the same time, to be focused on the group. So we so the rest is the same kinds of group rules that we usually would use in person, but these are, I think what I just mentioned are really important to stress. And at the first meeting, I make this really clear, because we want the group to be enjoyable and to be a safe place for everyone. Well, most of you, I guess most of you know the group that we offer. So it's the same. So we offer it the same way. We do it 24 sessions. We do twice a week. Some settings prefer doing it once a week, but we, in our pilot study, because it's in first episode psychosis, we've always done it twice a week. So we continue doing twice a week for 3 months. As you know, the workbook targets, you know, dysfunctional thoughts and behaviors, and how to modify or change or find new coping strategies. And it also works on self-esteem and other emotions, and social support. We talk a bit about substance abuse and suicidal tendencies, and also how to prevent relapses. What I tend to recommend in person and in the same way when we're doing it in teletherapy is I make sure every participant gets the full copy of the workbook before the first session. And instead of just sending like, oh, today we're doing this, like just the session in advance, I tend to send the whole workbook in advance. And there are many reasons for this. One of the reasons is really because of, it makes people who are a bit paranoid or a bit worried, it gives them an idea of what's going to happen. So it really reassures them. So they're not so scared that we might be talking about something that they don't want to talk about. So it's a good way of just reassuring everybody. And it's like, okay, this is going to be safe. This is a group that I can take part in. If there's something I don't want to talk about, I don't have to. And so they know what's going to happen. So it's very reassuring. Having the group, we give it once, the same, you know, when we meet them before, they have the workbook, and they never forget it afterwards. They're at home, right? So they have access to it, and if they want to do their homework, it's easy. They want to go back and see what they've done before, it's easy. And so that's something that we do before the first session. We give them a full copy of the workbook. Another thing is that, as I mentioned, we sent a Zoom link before each session. I mean, you could decide, because in Zoom or in another platform, you could decide to have like recurrent sessions where it's always the same number for the session, and that's fine. It doesn't have to be a new number for each session. It could be the same number, but you want to send it back to remind them. You don't want to have to look through all their text messages or through all their emails to find the number for each session. So by sending it back, it's like a reminder. And if they're confused, like Sarah was before, not knowing that we were Monday, or like if you're lost in time or in space, it's a good way of saying, oh yeah, okay, it's today. Because with the pandemic, a lot of people are confused. We lose track of time. I don't know if you've spoken to a lot of your clients, but I have quite a few clients that they started reversing their days and night. Like they're so messed up of not having a normal schedule that they're going to bed at 4 in the morning and getting up at 2 in the afternoon. So just to have this reminder, like, okay, don't forget the groups, and we're going to see you later on, and we're going to see you at this time, and this is a link. It is a good way of making sure that they'll be there, and a good reminder, and it gives them the structure. So it's something that we do. So we also text or call participants if they missed a session, just to know what happened, to say, hey, you know, I hope you're doing well, and make sure we're going to see you next time. Do you want us to go over what we did today? And it's a good way of making sure they don't drop out. Okay, let's see. Now, did we change anything? There are things that we kind of needed to change because doing it online is not the same as doing it in person. But overall, I'd say the group activities stayed the same. Like there's no session that we just took out or we said, oh, we're not doing this one because it's not possible. We even did the role plays. So for those who've done the group before, there are role plays where some of the co-therapists will do a role play, and the other co-therapists will like lead the participant in asking questions and trying to find, you know, together like, okay, do we have enough proof? And so there's like there's one role play in the how not to jump to conclusions activity, and there's another one with the suicidal idea, the suicidal participant, which is actually a therapist that's playing someone that's suicidal, and the rest of the group is asking questions. We still do the role plays. The difference is that when I do it in person, in a real group, in a live group, I would tend as a therapist to kind of move back a bit and show that I'm in a role, I'm in a character, and I would put something to disguise myself, like a hat or a scarf, and say, okay, now I'm in a character. My character's name is so on. We do the same, but we don't withdraw because we stay, you know, in front of the camera. But we'd say, okay, well, I'm going to play the character of Andrew. So right now, I'm Andrew, and then I put a scarf on and say, you know, this is just to show that I'm in character and I'm Andrew. And when I'm out of character, I'll remove whatever little piece of clothing that I added on. So we do it the same way, and it works. It's important to not over disguise yourself, but just to show, you know, when you're in character and you're not in character. I do this because it's happened at times where people kind of confuse the therapist with the character, and I don't want people in the group to start thinking that I'm suicidal. So it's a good way of you know, making a distance, and by saying it, okay, well, with putting this on, I'm in character. You can still do this online. As you know, or you might not know, but with Zoom, and probably with other platforms as well, but with Zoom, when I'm sharing the screen, I can also share, I'm going to show you, I could share a whiteboard, okay? So this is a whiteboard, and I could use it the same way as we would use a flip chart. So if I wanted to say, well, today's rules, so what rules do you want to vote on? And I could type it, and everyone gets access to it the same way as you would, you know, with a flip chart. And if somebody says something that's, oh, really important, and you want to circle it, well, you could say, hey, this is great, guys, you know, and you know, it's not a really nice circle, but anyway, you're getting the point. So that is something that you could also do with, okay, where'd it go? Oops, I just lost, there's my PowerPoint. Okay, it's also something that is very useful. So you can still have that like whiteboard or flip chart that you'd use normally in a group, but you can use it with Zoom. We also kept at the end, well, with COVID, I'm not sure you'll be able to do it, but maybe we'll be out of it by then. But when we did it outside of COVID, we'd have a graduation party in person at the end, where we'd all, you know, go to a restaurant that they picked or went bowling or something. So they'd get a chance to meet in person once. They all receive their diplomas in person. But with the COVID, that's probably not going to happen, but we still try to make kind of a festive last session together once it's all finished, or you know, having just like chatting about anything, how they liked it, and just exchanging about how it's great to have, you know, covered all of this together and gone through 24 sessions. Like, oh my God, a lot of people have never even graduated from school or never got any diploma. So it's something that is also often experienced as extremely positive to have like this end party at the end. So if it's possible, it's something that is very useful. Another thing, well, what we did change, okay, those are the things that we didn't have to change. So what we did change is that we cannot offer snacks at the end of each session. obviously, because we, we're online, so I can't just go out and send out snacks. So we didn't have that socialization snacks period at the end that we usually try to have when we're doing the groups in person. There's also a session or two that we actually ask people to kind of work in pairs before coming back, the whole group together. Well, we can't do that. So we did the whole group together the whole time. And so the idea is that all the activities are done together. The homework is reviewed together. When they come back after the next session, instead of kind of going through individually, we all do the homework together. No one ever forgot their workbook because they had them with them. And because we didn't, even if we say, oh, if people want to stay at the end and chat about other things, most people, when someone leaves the teletherapy, it kind of creates a movement where everybody leaves. And so we I'm getting messages at the same time. Okay, I'm gonna look at that afterwards. So we proposed a check-in instead at the beginning. So instead of doing socialization at the end, we do a bit of a checking in the beginning so people can share how they're doing. If you don't mind, I'm just gonna answer the questions afterwards. So in terms of our preliminary results, so one of the things we wanted to look is if we got a difference in attendance. And I only have results but on 10 people. And so we didn't find any difference in dropouts between in-person and online. We usually lose about 2 people in the first 2-3 sessions in person, and the same thing happened online. So we started with 8, ended up with 6. We did find we had fewer missing sessions online, and I think these were mostly due to transportation issues and to weather issues. I know in Seattle it rains a lot, but in Montreal it can get really cold and snowy, and so if the weather is bad, sometimes people don't want to come, or if it's the end of the month and they don't have any money, they can't pay for bus tickets. So we didn't have those issues. So we had less missed sessions than we would have had in person. And we actually did end up having people that would not have come to a group in person because they had social anxiety. And one person actually said, well, I would never have come if it had been in person. So she was really glad that we had offered it online. In terms of scores, these are very preliminary, but essentially we did get similar improvements because total score for positive symptoms, like, I got a very small n here of 8, but there seems to be a trend that it's going to be positive, and for self-esteem as well. And we'd have to get at least 60 to really be able to compare with our other studies, but it seems to go in the same direction. So it seems to be helping. The qualitative results that we got were very positive as well. Our sample was mostly male, average age about 25, and mostly single. This is what I wanted when I was talking about Alliance before, and I think this is really important slide because the top part of the slide is a study we did with 66 people with the first episode of psychosis who received the Group CBTp, and we measured Alliance at session 8, 16, and 24. And we took the same measures here, and this is only an Alliance assessed by the participant. And what we see is the higher the score is, the better the Alliance, and we're not getting lower scores. Okay, it's a small sample, it's 10 people, but still, for us, this is a good sign. So it doesn't seem that the Alliance is worse. It seems that the Alliance is just as good and perhaps even a bit better at the moment, which might change over time, but still it's very promising that participants still feel that they're connecting and that they're connecting with the others and they're connecting with the therapists. So that was something that was very positive. So in conclusion, and now I'm going to look at your questions, what we, so far, I mean, we're still studying it. It's a very small pilot study, but in the past year and a half, what we found is it's acceptable, it's feasible. We offer a group CBTP via teletherapy. Our pilot results seem to suggest that the results are going to be similar in terms of outcomes that what we've seen in other studies. and that there doesn't seem to be a big difference in alliance. So for us, this is a good sign, and that's, you know, why I could recommend for you guys to use it, because so far there's no I guess non-recommend, like there's no negative effect that we've seen, and it seems that the results are going to be as good as in person. So that was my brief presentation and my COVID quote: if you're not a mess, you are not a mess, you're a feeling person in a messy world. So that's my little quote. So
I'd like to once again thank Dr. Lecomte for joining us and lending us her expertise, sharing the results of her pilot evaluation of administering CBT for psychosis in group format via telehealth. And thank all of you for making the time to attend the webinar. We would love to have you reach out to us at the Northwest Mental Health Technology Transfer Center. You can reach us online at www.mhttcnetwork.org/northwest. Follow us on social media at Northwest MHTTC, or email us at northwest@mhttcnetwork.org to find out about upcoming trainings, new online trainings, as well as resources and research updates.